Although this discussion will be primarily about the inguinal canal, but as I had mentioned before, we will start with the inguinal ligament. We'll study the inguinal ligament because inguinal ligament has a bit of other associated structures, the anatomy of which is very crucial for understanding inguinal canal. Okay, because everything that will be we'll be talking about in this discussion will be incredibly, I might say, conceptual and visualization worthy, and the inguinal ligament, inguinal canal and all the associated structures and the anatomy of this region, it's a little three-dimensional, so it's a little difficult to completely establish all of that on a paper, but we will use Netter's Atlas and the 3D app to even the odds, you might say. So we start this discussion with the discussion about the inguinal ligament. Now, inguinal ligament, as I had mentioned previously in a previous discussion, that inguinal ligament is nothing but it's a false ligament, by the way. It is nothing but the thickened folded part of the external oblique aponeurosis. So this over here we have drawn, this is the inguinal ligament. Okay, I'm abbreviating it, hope you understand. So inguinal ligament, this is actually formed by the external oblique aponeurosis. So a ligament is not supposed to be, normally a ligament is not supposed to be formed from a muscular structure. It is supposed to be an osseous structure, a fibrous structure, but in this case it's a musculo-aponeurotic structure. So that's why we say that the inguinal ligament is a false ligament. It's not a true ligament. It's formed due to the upturned folding of the inferior border of the external oblique. By the by, from where to where exactly does this extend? Very simple. This extends from, I'm writing it abbreviated, anterior superior iliac spine of the hip bone. Anterior superior iliac spine extends downwards and medially and attaches to this point, which is called the pubic tubercle. Very, very important point. This pubic tubercle will serve as a point of attachment for many other associated structures of this region. So it's very important. So that's the attachment of the inguinal ligament. So far so good, pretty easy to understand, right? Now try to understand this. Inguinal ligament is formed by the upturned or folding of the external oblique muscle, right? So if we are to take a, you might say, sagittal section, very roughly speaking, we will see that this is the external oblique which is coming down, 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 and then it is folding like this. This region is the inguinal ligament. So this folding, since this is the inguinal ligament, what we say is that the inguinal ligament, this is grooved in its upper surface. The fact that the inguinal ligament is grooved in its upper surface is the foundation for the inguinal canal, which we will talk about in just a bit. All right. So do you understand why the inguinal ligament is grooved in its upper surface? This is the reason. So far so good, right? Right. Let's now talk about the structures which are attached to the inguinal ligament. If you can understand that this is the hip bone, you can pretty well appreciate that the structure which will be coming downwards, the gross anatomical domain coming downwards, is the lower limb, right? The thigh will be starting from over here, right? So inguinal ligament is serving as a boundary. It's serving as a boundary between the abdominal region and the lower limb region. Consequently, if you remember or if you know this, we'll talk about this in a separate discussion, or we'll talk about this in a separate video, that the fascia of the lower limb, grossly it is known as the fascia lata, right? Fascia lata. This fascia lata, this is actually attached to the lower surface of the inguinal ligament, and that makes sense, right? Fascia lata, obviously it will be surrounding the lower limb regions, right? So the upper part of the fascia lata, we can appreciate that it will be attached to the lower surface of the inguinal ligament, right? As far as the upper surface of the ligament is concerned, this is something that we have already talked about when we were talking about the origin insertion, or rather the attachments of the anterolateral abdominal wall muscles. We had said that the internal oblique muscle and the transversus abdominis, both of them take origin from the lateral part of the inguinal ligament. To be a little bit more precise, internal oblique takes origin from the lateral 2/3, whereas transversus abdominis takes origin from the lateral 1/3 of the inguinal ligament. Obviously, this is not the only point of attachment for those muscles. Their origin insertion is pretty extensive. We had already talked about that. But this is actually serving as a line or point of attachment for those two muscles. So let's just get that out of the way first. Now, the extensions of the inguinal ligament is the reason that this diagram exists. I started with this diagram because this is incredibly simplified a diagram, but this is incredibly important and fundamental as well for understanding that inguinal ligament, although it extends from this to this, anterior superior iliac spine to pubic tubercle, but there are some other structures which are associated with it, which we might say to be extensions of the inguinal ligament. Okay, so there are a few extensions of the inguinal ligament, although we say that it's actually extending from here to here, but a few fibers of inguinal ligament will give origin to some other structures. Let's one by one talk about them. All right. The first fibers that we do talk about, let's talk about these fibers, the fibers that are arching upwards and medially. This dotted line is the midline of the body. If you remember, what structure was this along the midline? Very good, the linea alba. So for all intents and purposes, we can label this as linea alba. Okay. So these fibers that are arching upwards and medially, right? Obviously they are starting from the pubic tubercle, arching upwards and medially. Then they're continuous with the opposite sided fibers of the same thing. These are what we call to be the reflected part of inguinal ligament. This is a very important structure. Why this is a very important structure, why its anatomy is very important to understand, is because this is something which is related to the inguinal canal, right? So this reflected part of inguinal ligament, this is nothing but an extension of the actual inguinal ligament. It's looking as if the inguinal ligament is getting reflected, right? Inguinal ligament stops here, reflected part of inguinal ligament starts from here. So it's looking as if the inguinal ligament is getting reflected along this part. So these are fibers which are actually passing upwards and medially. Okay. Now, the real thing here is that you can see here, I hope you can appreciate that this thing, this U-shaped thing that has been drawn, this is nothing but the superficial inguinal ring. So when we talk about inguinal canal, we will come to know, or I had already mentioned previously in a discussion, that superficial inguinal ring is nothing but an opening. It's a gap present in the external oblique aponeurosis, present just superolateral to the pubic symphysis, right? It is a gap, it's a opening, you might say, the superficial inguinal ring, and it serves as the outlet for the inguinal canal. We'll talk about it in just a bit. Why I mentioned this in perspective to reflected part of inguinal ligament is to point out to the fact that the reflected fibers of inguinal ligament, they pass behind the superficial inguinal ring. That's why you can see that they are dotted here, right? Right. So this is an important thing. Keep this in mind, that the reflected part of inguinal ligament passes behind the superficial inguinal ring. How this will be necessary to remember or understand later is when we will talk about the relations of the inguinal canal. Okay? Okay. So this is just a fact which is crystal clear from this diagram. Having talked about the reflected part of inguinal ligament, now we are in a position to concentrate more medially at these structures. See, can you see these three lines that I have drawn? This is representing the lacunar ligament. Okay? This is the lacunar ligament, or there is another name for this. It is known as the pectineal part of inguinal ligament. Why I had to mention both of these names is obviously since lacunar ligament is the more catchy name. So you will obviously remember that. Why I mentioned pectineal part of inguinal ligament as well is because if you remember that this part is also known as the pectineal part of inguinal ligament, you will automatically remember, since there is a pectineal in the name, you will remember that an attachment of this ligament will be at the pecten pubis, right? So it's a free mnemonic, so you should take it, right? It's a free mnemonic. Just by remembering that this part is called the pectineal part of inguinal ligament, pectineal, so it has an attachment at the pecten pubis. Okay, so anteriorly, if you can understand, see again, this is a three-dimensional model. All right, we'll see to this in the atlas as well, but this is a three-dimensional model. So this is more anteriorly, the inguinal ligament is more anteriorly, and this, although it is looking as if it is superiorly, this is actually a little posteriorly. In the 3D model, this lacunar ligament, the pectineal ligament, these are posteriorly oriented. All right. So this lacunar ligament, it is actually attached, the anterior part of the lacunar ligament, this is attached to the medial part of the inguinal ligament. Very, very clear from here, right? As you can also see that the lacunar ligament is a triangular ligament, very, very self-evident. So it has a base and an apex. The apex obviously is attached to the pubic tubercle, no problem with that. Whereas, as you can see, the base is kind of free. It is free, not really attached to anything. Okay, okay. So that's that about the lacunar ligament, I guess. And this is actually, okay, so this is the, as I mentioned, this is a 3D model. So inguinal ligament is more anteriorly, this is more posteriorly, and this lacunar ligament, this is somewhat horizontal. Can you imagine how the lacunar ligament is placed? We'll see to that in the model. Just remember, for now, you will understand it later, that the lacunar ligament is horizontally placed. And obviously, it has an anterior part attached to the medial half of the inguinal ligament and a posterior part. Oh, by the way, I actually forgot to mention the posterior part. The posterior part, as you can see, it is actually attached, or rather it is giving origin to another extension of the inguinal ligament. This is called this line. See, the posterior part, they are attached to this line, or rather actually from this posterior fibers, posterior part of the lacunar ligament, this fibers or this ligament is coming into play. This is called the pectineal ligament. Okay, so this is called the pectineal ligament. So posteriorly, this lacunar ligament is attached to the pecten pubis. Remember, I had said that the pectineal part of inguinal ligament, pectineal, this part is coming in the name, so it is the pecten pubis attachment. It has a pecten pubis attachment. Where exactly does it have a pecten pubis attachment? Along the posterior part. Now see how well this goes with the logic that since this ligament is called pectineal ligament, this pectineal ligament is attached along the pecten pubis as well, which actually checks out because the lacunar ligament's posterior part is attached to the pecten pubis, and the pectineal ligament along here there is the pecten pubis, so the pectineal ligament is also attached along the pecten pubis, right? And it is actually an extension, as I mentioned, from the posterior part of the base of the lacunar ligament, and obviously it is attached to the pecten pubis, right? The last kind of fibers that remain, the last extension that remains, is given off from the inguinal ligament's middle part, somewhat middle part. This is what we call to be the inter-crural fibers. See, I had mentioned about the superficial inguinal ring, right? These two sides of the superficial inguinal ring, by the way, the superficial inguinal ring is somewhat triangular in shape. So the two sides of the inguinal superficial inguinal ring, they are called the two crura. They are said to be the two crura of the superficial inguinal ring. From the lateral crura of the superficial inguinal ring, the reflected part of inguinal ligament takes origin. So I had mentioned that the reflected part of inguinal ligament, it is coming from the more or less the pubic tubercle, but from where exactly is it taking the origin? It is taking origin from the lateral crura. This is the lateral crura, this is the medial crura. I hope you can get that. From the lateral crura of the superficial inguinal ring. I had forgot to mention that, I'm sorry for that. Right? Right. So what does that have to do with intercrural fibers? Now see, the name itself is telling you intercrural, and I just mentioned that these are the two crura. So intercrural fibers, what they are doing, they are running from the middle of the inguinal ligament towards the two crura, and they are actually keeping the two crura attached together. They are actually keeping the crura attached together. In the atlas, this will be very much clear as to how this is happening. Okay, so this is just to give you a basic overlay, a very simple overlay of the inguinal ligament and its parts. Now let's move on and see these things in a little bit more detail. Let's start with the actual inguinal canal, right? Right. Now let's talk about the inguinal canal proper. All right. Right. So as you can all see here, we have a 3D anatomical model, and on one side we have all the muscles of the anterolateral abdominal wall, whereas on the other side we do not have as many muscles. So compare these two sides. This over here, this is obviously the external oblique muscle. This is the rectus sheath, which has been shown in this model. All right. Now, can you see that at the very inferior edge, just superolateral to the pubic symphysis, there is this opening in the external oblique aponeurosis. This is what we say to be the superficial inguinal ring. All right. So this is the superficial inguinal ring on both sides. Very carefully now see that the superficial inguinal ring, how that is related to this structure. This is the inguinal ligament. See, This is the inguinal ligament. All right. So this is the superficial inguinal ring. This is the inguinal ligament. Right. Right. So why I'm showing you these two structures is to set the idea of how this inguinal canal is formed, or rather how this inguinal canal is oriented. So inguinal canal, what is it actually? First of all, let's define it. It is nothing but an oblique, obviously we can see that this is oblique, musculo-aponeurotic canal. So it has both muscular constituents, as we will see, and it also has aponeurotic, as we can see, components. So it's a musculo-aponeurotic canal, obviously situated in the lower part of the anterior abdominal wall. And how it is oriented, as I already said, it is oriented along the medial half of the inguinal ligament. So it actually kind of uses the medial part of the inguinal ligament to reach this superficial inguinal ring from where it exits out of the abdominal cavity. But from where does it start? If there is a superficial inguinal ring where it ends, which is the outlet, where is the inlet? That is exactly where the deep inguinal ring comes into play. So see, I have exposed this fascia, which is the fascia transversalis. Over this side, the fascia transversalis is not exposed, so we can get the overall idea that all these muscles are covering the fascia transversalis. But in the exposed side, we can see that this is the fascia transversalis, right? Now look how on the fascia transversalis, there is this opening over here. Can you see the opening? This is situated on the fascia transversalis. So the superficial inguinal ring, this is situated on the external oblique aponeurosis, whereas this opening is situated on the fascia transversalis. This is called the deep inguinal ring. This is called the deep inguinal ring. Okay. So see, this is the deep inguinal ring. It is very faintly given because the fascia has been given as a transparent structure. This is the deep inguinal ring. This is the superficial inguinal ring. This is the inguinal ligament. So see, can you now get an idea of how the inguinal ligament, or rather how the inguinal canal is oriented? It is oriented downwards, forwards, and medially, positioned across the medial half of the inguinal ligament. Okay. It starts from the deep inguinal ring, which is the inlet, ends at the superficial inguinal ring, which is the outlet. All right. Now, as far as the position of the deep inguinal ring is concerned, there is a very famous number, that is 1.2 centimeters. It is approximately this deep inguinal ring is approximately 1.25 or 1.2 centimeters above the mid-inguinal point. So what is the mid-inguinal point? This is the inguinal ligament, right? Now, there is a midpoint of this inguinal ligament, a middle of the inguinal ligament. That point is called the midpoint of inguinal ligament. But if we consider from the anterior superior iliac spine to the pubic symphysis and not up to the pubic tubercle, that is the inguinal ligaments attachment. If we extend the line up to pubic symphysis and then consider its midline or midpoint, the point that we get is the mid-inguinal point. So we have 2 points. One is called the midpoint of inguinal ligament, which is nothing but obviously the midpoint of the line joining anterior superior iliac spine and the pubic tubercle, that is inguinal ligament. The midpoint of that, midpoint of inguinal ligament. But there is another midpoint, that is the midpoint of the line joining anterior superior iliac spine to the pubic tubercle. No, not the pubic tubercle, the pubic symphysis. Pubic tubercle is inguinal ligament. Pubic symphysis, up to that, if the line is extended and the midpoint of that is concerned, it is a mid-inguinal point. So mid-inguinal point, from that, suppose this is the mid-inguinal point, from the mid-inguinal point, above about 1.2 centimeters above, the deep inguinal ring is present. On which layer is it present? It is present at the fascia transversalis. Where is the superficial inguinal ring present? The external oblique aponeurosis. Okay. Now, obviously, the outlet is present in the external oblique aponeurosis. The inlet is present in the fascia transversalis. In between them, there are a lot of layers. I mean, there are these two muscle layers, obviously, the internal oblique and the transversus abdominis. They will also form some parts of the inguinal canal. Now we have to visualize the actual inguinal canal, and since this is actually a canal, so what it will have is, it will have some anterior relations, or rather the anterior wall. It will have a posterior wall which is situated behind the inguinal canal. It will have a roof. The structure, obviously it's a canal, so it's a closed canal like structure, that's why it's a canal. So a roof will have to be formed for the canal to be complete, and a floor has to be formed for the canal to be complete, right? Right. So for that, to understand those aspects, uh, what we need to do now is we need to take a look at the atlas diagram, because the 3D model is not that detailed to understand the anatomy of the inguinal canal completely. This is just to give you an orientation of how the canal is positioned, right? Right. So now we have in front of us a very complicated looking diagram, but this is a very, very important diagram, and this is very easy to understand. Trust me. All right. The first thing I would like all of you to appreciate is the layers of the anterolateral abdominal wall. Very quickly, please appreciate the layers. The very first layer that we see, this is the external oblique muscle. Undoubtedly the external oblique muscle. Then this is the internal oblique muscle. Look carefully at the mouse pointer. This is the internal oblique muscle. This over here is the transversus abdominis muscle. Okay. And then we have the fascia transversalis. So can you all appreciate the four layers? The external oblique, internal oblique, transversus abdominis, fascia transversalis. The four layers. Now, let's see, or rather let's try to understand how the inguinal canal is present. See, this is the external oblique aponeurosis. This over here, can you see an opening? This opening, this is what we call to be this bulged opening. Can you see this bulged opening from where this tube-like structure is coming out? This tube is not the inguinal canal. This tube is a part of the inguinal canal. That is a constituent. What structures are present inside the inguinal canal? When we'll talk about that, we'll talk about this tube-like structure, which is nothing but the spermatic tube, right? So we'll talk about that later, or rather the spermatic cord actually. So this tube is, for all intents and purposes, you can consider that this tube is a constituent of the inguinal canal. But see, from where is the tube coming out? From this bulged opening, we can all appreciate that is the superficial inguinal ring. We can all appreciate the bulging over here, which is signifying that there is an opening or there is a canal over here. That is the inguinal canal. Okay, so over here the inguinal canal is extending, and it is going posteriorly. So this is how the antero-posterior relations work. This is very difficult to show on a 2D paper with a normal diagram. That's why the atlas is required. Now, remember that this is the transversus abdominis. So, in the transversus abdominis, we had what? The deep inguinal ring, right? So, what is actually happening? Now, listen to me very carefully. The deep inguinal ring is present somewhat over here, the fascia transversalis. The superficial inguinal ring is present over here. The superficial inguinal ring is triangular in shape. The deep inguinal ring is oval in shape. And the superficial inguinal ring, it has these two crura, as I had already mentioned, the lateral crura and the medial crura. This over here, do you see these fibers? These are the intercrural fibers. See? So this is how you visualize the intercrural fibers. Can you see them? These are the two crura. These are the two crura, right? And these are the intercrural fibers. This over here, do you see? This is the inguinal ligament. Okay, this is the inguinal ligament. So now let's get on with this very systematically. Okay, let's get on with this systematically. What will form the anterior wall of the inguinal ligament? What are the structures present anteriorly? So obviously, skin, superficial fascia, these two structures will obviously, they are untouched. So obviously they will form the anterior wall of the inguinal canal. No problem in that. Next, the external oblique aponeurosis. Obviously, the external oblique aponeurosis is anteriorly located to the inguinal canal, right? So no problem. Now, these three structures that I just mentioned, the skin, the superficial fascia, the external oblique aponeurosis, these are structures which are forming the anterior wall of the inguinal canal throughout its extent. That is, there is no such part of the inguinal canal where the external oblique is posteriorly located. There is no such part of the inguinal canal where the external oblique or the skin or the superficial fascia, they are posteriorly located, or they're forming the roof. Nothing. They are always anteriorly located to the inguinal canal. Obviously, since the superficial inguinal ring is present in the external oblique aponeurosis, so external oblique aponeurosis is a broad aponeurotic sheath present superiorly, and obviously it is the anterior most muscle of the anterior abdominal wall, right? So throughout the extent of the inguinal canal, external oblique will always be the anterior wall of the inguinal canal. But there is this one muscle which is anteriorly located to just a part of the inguinal canal. That muscle is the internal oblique. This was the external oblique. This is the internal oblique muscle. Now, see very carefully. Do you see that the internal oblique over here, it is actually arching above or upwards over the inguinal ligament? You can see that, you can visualize that this is the inguinal ligament, because the spermatic cord, which is a very major constituent of the inguinal canal, that is actually bulged over here. So it is passing through here. So this must be the inguinal canal, right? See how the internal oblique fibers are arching upwards above the inguinal canal, and they are present anterior to the inguinal canal. Now, see, inguinal canal is passing posteriorly. They're passing posteriorly. But in the lateral part of the inguinal canal, the lateral part, this part of the internal oblique, this is anterior to the inguinal canal. Can you visualize? See, from here, the inguinal canal is starting, or rather, it's actually starting and exiting from here. That we know. But what's happening is the internal oblique muscle fibers, they are arching above the inguinal canal, and in the lateral part of the inguinal canal, or rather in the lateral one third of the inguinal canal, this part, they are forming, this part of the internal oblique is forming the anterior wall of the lateral one third of the inguinal canal, right? The fleshy fibers of the internal oblique, can you visualize? Then it is arching upwards and forming the roof of the inguinal canal. Okay, so anyways, we'll talk about the roof in a bit. So can you visualize how the anterior wall is formed? Anterior wall, obviously skin, superficial fascia, external oblique aponeurosis. As far as the entire extent is concerned, these three are the structures. No problem with that. The only problem with visualization which I can imagine is the internal oblique being a part of the anterior wall. How? Only in the lateral part. See, this is the lateral part, this is the medial part, right? So obviously, since this is the inguinal canal, these are the anterior structures. This is the anterior side. Can you understand? This is the anterior side. So just this much part of the internal oblique is anterior to the lateral one third of the inguinal canal. See? Right? So in the lateral one third only, the internal oblique is anteriorly present. Right? Right. So that's the anterior wall accounted for. What about the roof of the inguinal canal? As I mentioned, since this is a canal, so there has to be a roof, there has to be a floor, and there has to be the walls. That is the anterior wall and the posterior wall, right? The roof of the inguinal canal is formed by, see, as I said, the arched fibers of the internal oblique, and you can see that there is another muscle which is arching, the transversus abdominis. So the internal oblique and the transversus abdominis, both of these muscles, their fibers arch over the inguinal canal, forming the roof of the inguinal canal. Okay, so that's pretty easy, right? Now let's talk about the posterior wall of the inguinal canal. So now we are moving to the posterior side. If you remember, this was the fascia transversalis, which lodged the deep inguinal ring, right? So the fascia transversalis, this actually forms, obviously, just like external oblique formed anterior wall throughout the extent, fascia transversalis also forms throughout the extent of the inguinal canal. It forms the posterior wall of the inguinal canal. Now, behind fascia transversalis, there is extraperitoneal tissue. So obviously that is a part of the posterior wall as well. Again, throughout the extent of the inguinal canal. And there is the parietal peritoneum as well. So there are three layers. The fascia transversalis, separated from the parietal peritoneum by the extraperitoneal tissue. Then the actual abdominal cavity starts. From the parietal peritoneum part, the abdominal cavity has started. But we are right now in the abdominal wall, anterior abdominal wall. So these three structures, the fascia transversalis, the extraperitoneal tissue, and the parietal peritoneum, they actually form posterior wall throughout the extent of the inguinal canal, because there is never a part where inguinal canal they are anterior to the inguinal canal, they're lateral to the inguinal canal. There's never a part like that. All right, throughout the extent they are posteriorly located. However, again, just like the anterior part, there are a few structures which are posteriorly oriented only at certain parts of the inguinal ligament and not throughout its entire extent. Again, I draw your attention to a very important structure which we have not talked about as of yet. See, the more lateral that we go, the more diverging the internal oblique fibers and the transversus abdominis fibers become. Obviously, they should, because they are different muscles. So why should they converge? They should not converge. But medially, they do converge. And this is something which is pertaining to rectus sheath. And I had actually forgotten to mention this. I'm pretty sorry. That in the rectus sheath, since this is what part of the rectus sheath? This is below the arcuate line. Obviously, we are talking about the pubic region here, the inguinal region that is completely inferiorly located, right? So this is much below arcuate line, and so obviously transversus abdominis will be anteriorly oriented. But a very interesting thing happens here. Fibers, or rather the lower fibers of the transversus abdominis, they fuse with those of the internal oblique, and together they form a structure which is very aptly said as the conjoint tendon or inguinal falx. This inguinal falx is a very important concept to understand, that it is nothing but the conjoint tendon. So, conjoint fused union of the inferior fibers at the midline, not at the lateral sides. This is something that always used to confuse me personally as to how a conjoint tendon is present coming in the relation of inguinal canal, and yet you're getting arched fibers of separate transversus abdominis and internal oblique later. This used to confuse me. Later I understood that this conjoint tendon is only medially present, not laterally present. Laterally, these muscles are completely separate, arching over the inguinal canal, forming the roof of the inguinal canal. But medially, they form the conjoint tendon. Because in the rectus sheath formation, we had actually missed out this point, but this is an important point to remember, that in the anterior portion below the arcuate line, where all the three muscles and their aponeurosis are anteriorly located, the fascia, the transversus abdominis and internal oblique, they're fused, whereas this external oblique remains separate. So together they form the conjoint tendon. Why I'm mentioning conjoint tendon, conjoint tendon, I'm sorry, right now, is because conjoint tendon is, as you can see, posterior to the inguinal canal. Can you see? This is the inguinal canal coming like this. We are visualizing, actually, we are visualizing the spermatic cord as the inguinal canal, because for all intents and purposes, it is like completely filling up the inguinal canal. So we can visualize, for simplicity, we can visualize the spermatic cord as the inguinal canal as well right now. So anyways, so see, this conjoint tendon, this is posterior. This is posterior to the inguinal canal. These structures, these are posterior. These structures, these are anterior. So anteriorly, we don't actually consider transversus abdominis as an anterior relation, right? We do consider, although, the internal oblique as an anterior relation in only the lateral 1/3. Can you visualize why? This is the inguinal canal. Anteriorly, this is the uh, internal oblique only in the lateral 1/3. Whereas this side is the posterior side of the inguinal canal, because the inguinal canal is oblique. So anteriorly, this is the anterior side, this is the posterior side, right? So conjoint tendon at the medial 2/3, not entirely, because later on, as I said, laterally they separate. But in the medial 2/3 of the inguinal canal, the conjoint tendon serves as a important posterior relation or posterior wall of the inguinal ligament, right? Now try to remember another structure which I had said which is an extension of the inguinal ligament, which moves behind the superficial inguinal ring. I had just said that. Yes, the reflected part of inguinal ligament. So the reflected part of inguinal ligament is not really shown here because it has been covered up by the presence of the spermatic cord over here. So anyways, so it has not been shown here. No. So as I already mentioned that from the lateral crust, so this is the lateral crust, this is the lateral crust. From the lateral crust, the reflected part of inguinal ligament that will move medially along the linea alba, it will move. And from there, it is continuous as the reflected part of inguinal ligament for the opposite side. So the reflected part of inguinal ligament is actually present behind the superficial inguinal ring, but in front of this conjoint tendon. So both the conjoint tendon and the reflected part of inguinal ligament are posterior only to the medial part of the inguinal ligament and not the lateral part. Now here is where let me tell you how to develop this concept, or rather how to remember, kind of. You should not actually memorize, you should visualize. So since this is a very oblique structure, what's actually happening is that in the medial part, anteriorly there is no space left for any relation of the inguinal canal. But posteriorly, there are some relations left in the medial part. Whereas in the lateral part, posteriorly, there is not much left. But anteriorly, there is left. I probably confused you. This is how I actually remember that where exactly are these posteriors and anteriors located. Since this is so oblique a muscle, not a muscle, an oblique a structure, so it is so oblique that in the medial part, there is no space for any anterior relation of the inguinal canal. That's why in the anterior part, in the anterior wall, we had said that those three structures were covering the entire anterior wall for the entirety of the inguinal canal. But there was this one structure, which is the internal oblique, present anteriorly for the lateral one third, not the medial one third. That's now I'm telling you how you will remember that it is the lateral one third. How you will remember is by the obliquity of the inguinal canal. So it is oblique in such a way that there is space anteriorly only in the lateral side, but no space anteriorly in the medial side. Whereas there is space and posteriorly in the medial side, whereas there is no space posteriorly for the lateral side. No space, right? You may actually ignore the last few bits of things that I said, because in all intents and purposes it probably became a little bit too complicated. Anyways, so that's the walls and the roof accounted for. Now let's talk about the floor. The floor, as we all know, is actually formed by the obviously the inguinal ligament, rather the grooved upper surface of the inguinal ligament. If you remember, I had said that the inguinal ligament is grooved. So the grooved upper surface of the inguinal ligament forms the floor, but that is not the only thing. If you remember, we had also shown another ligament in this region. What is that? It is this. We are seeing inferiorly. This is the lacunar ligament. Do you see the lacunar ligament? Right. This is the lacunar ligament. The lacunar ligament also forms a part of the floor of the inguinal canal in the medial part of the inguinal canal. So for the majority of the inguinal canal, it is the grooved upper surface of the inguinal ligament. No problem. But only in the medial part, since the lacunar ligament is present medially only in the medial part. This is the inferior view, by the way, inferior view, inferior view. So only in the medial part, the lacunar ligament uh, is actually present, and that is actually forming the floor of the inguinal canal, right? Now, what about the constituents of the inguinal canal? Now, this is purely theoretical. This is purely theoretical. There is nothing much to understand here, except the fact that how the inguinal canal, or rather, what is the reason for the inguinal canal to exist? I mean, you potentially have a very weak space, a, a canal which is uh, connecting the internal abdominal space to the exterior. Why would you have that? That's a risk for the body, right? Because abdominal organs may herniate out through it, which we will see when we talk about inguinal hernia later in a later discussion. So, even then, why is it present? It is present for one purpose only. It is present for the descent of the gubernaculum in the embryonic state, in the fetus state. So gubernaculum, it is actually, you may have heard about it, it's a fibrous cord-like structure which attaches the male and female reproductive, you might say, organs. For males it will be testes, and for the females it will be ovaries, to consequently other structures where in the future those reproductive structures will be present. So, for example, in males, the gubernaculum attaches the testis to the wall of the scrotum. Now, scrotum, as you know, is located outside the body, extra abdominal cavity, right? So, for the testis to descend down, for the gubernaculum to pass through from the abdominal cavity to the outside exterior, you need a passage, right? That passage is this thing, that is inguinal canal. So for the descent of the gubernaculum in both sexes, the gubernaculum is actually a guiding hand. So it actually guides the reproductive organs to their future sites where they will be present, right? That is the reason why the inguinal canal is present. So inguinal canal, what it transmits, gubernaculum does not remain, obviously it's a fetal structure only. What does remain is the spermatic cord in males and the round ligament of uterus in females, right? So round ligament of uterus is something that we'll study when we talk about uterus. But as far as the spermatic cord is concerned, what is the spermatic cord? So again, let's take a look at this thing. So this was the spermatic cord, if you remember, right? So see, spermatic cord is actually coming from a very deep, from very deep it's actually coming. This thing mixes with all of these things together, they're forming the spermatic cord. So spermatic cord, this is actually um, it what does it contain? It contains a lot of structures. What are these structures? Obviously, first of all, as you can see here, this is the um, vas deferens or the ductus deferens. You can see that it is coming from down below. It is coming and it is joining with these structures. So the vas deferens, which is coming and it is joining with these structures to form the spermatic cord. What are these structures? These structures, what are they actually? So they are some arteries, veins, nerves, and lymphatic tissue. What exactly are they? So, as far as arteries are concerned, the spermatic cord contains Number one, the testicular artery. The testicular artery. Number two, we will have the vas artery, or the artery for the vas deferens, or the artery for the ductus deferens. And we will have the cremasteric arteries. These are the three arteries that are present in the spermatic cord. So all of these three arteries, as you can already mention, or rather, as you can already notice from their names, they are related to structures of the male reproductive organs. Right. So there is this artery for vas deferens, which is normally a branch from either superior vesicle or inferior vesicle artery. Right. Just a side note you might take. So that's the artery to vas deferens. Then you have the cremasteric artery. Cremasteric artery, this is actually a branch of the inferior epigastric artery. So remember how important inferior epigastric artery was? So inferior epigastric artery, that actually gives off this branch of cremasteric artery, right? Right. Then the testicular artery, this is nothing but the gonadal artery. So that is actually what? A lateral branch of the abdominal aorta. We all know. So these are the three arteries which are present. As far as the veins are concerned, the veins are actually in the form of a plexus known as the pampiniform plexus. PAM, P-A-M, piniform, P-I-N-I-F-O-R-M. Pampiniform plexus of veins. Right? So that's arteries taken care of, veins taken care of. Now nerve. As far as nerves are concerned, we have, as you can all see in this diagram, or rather in this atlas, this nerve. Do you see this nerve? This is the genital branch of the genitofemoral nerve. See, this is also entering the spermatic cord, right? The genital branch of the genitofemoral nerve. Along with that, we also have a sympathetic plexus for the nerves around the different arteries. That is the artery to ductus deferens or other afferent fibers. So there is more or less a sympathetic plexus of nerves along with the genitofemoral nerves genital branch. These are the nervous constituents of the spermatic cord, right? Then we'll have some lymph vessels. We'll have some uh, extraperitoneal, or we'll have some tissue, loose areolar tissue will also have some. And we will have another structure. That structure is called the processus vaginalis, or rather, the remains of processus vaginalis. So, processus vaginalis is actually another fetal structure. It's not present in adults, but the remains of processus vaginalis is there. We'll talk about processus vaginalis when we talk about the reproductive organs. Okay? Okay. So, that's more or less what the normal constituents of the spermatic cord should be. But then again, some abnormal constituents might also be there in the spermatic cord. So, as far as the abnormal constituents are concerned, we might have, very peculiarly, we might have some accessory spleen in the spermatic cord, which is a very, very bizarre kind of abnormal constituent. You might have an accessory spleen in the spermatic cord. You might also have accessory suprarenal cortical tissue. Accessory suprarenal cortical tissue in this as well, right? Right. So that's the abnormal constituents of the uh, this spermatic cord. Now, apart from the spermatic cord is the proper constituent of the femoral canal. No problem. It enters from the, as you can see, this opening, deep inguinal ring opening. Not here, here, and exits through the superficial inguinal ring. But there is another constituent which is not entering from the deep inguinal ring, but exiting from the superficial inguinal ring. So it does not traverse the entirety of the inguinal canal. That structure is this nerve, the ilio-inguinal nerve. Ilio-inguinal nerve, I had mentioned that this is the neurovascular plane of the anterior abdominal wall. That is, in between the transversus abdominis and the internal oblique. So the ilio-inguinal nerve is coming from the posterior side or the posterior abdominal wall, and it's actually a lumbar plexus nerve. We'll talk about it later. It's coming anteriorly in between these two muscles, and it is actually entering the inguinal canal. So it does not enter the inguinal canal through the deep inguinal ring, right? But actually it will exit through the superficial inguinal ring. So in the midway section, it will enter, and thus it is just a partial content of the inguinal canal, right? Now, one other thing I forgot to mention about the spermatic cord. Spermatic cord, it is obviously constituted by all those structures that I just mentioned, but it also is constituted by some coverings. Now see, the coverings of the spermatic cord, they are very logical. Think about it. Spermatic cord is a structure which is arising from the posterior or deeper aspects, moving anteriorly and superficially. So, on its way, the coverings that it takes will be from the structures that it passes through. So, the first covering of the spermatic cord is known as the internal spermatic fascia, which is nothing but an extension of the fascia transversalis. Now try to think, the fascia transversalis is the first, you might say, barrier in a way in the path of spermatic cord in its path through the inguinal canal, because it encounters the fascia transversalis the first. It is coming from the deep, so fascia transversalis is the first deep structure that it encounters. So the internal spermatic fascia, see how logical it is. Internal spermatic fascia, that is obviously a covering derived from the fascia transversalis, because it is coming from the deep, and fascia transversalis is the first structure in this inguinal canal that it encounters. Then it encounters these two muscles. From them, primarily from the internal oblique, it will derive the next layer, which is more external to the previous layer, obviously. This layer is known as the cremasteric fascia. Cremasteric fascia. This is the cremasteric muscle. We haven't talked about cremasteric muscle. It's actually an extension of the internal oblique muscle. We'll talk about it later in a later discussion. But the cremasteric fascia is actually derived from the uh, internal oblique, more or less, muscle. And it is also actually constituted by the cremaster muscle. Or the, yeah, the cremaster muscle. So the second layer is the cremasteric fascia. Then the last one is the external oblique aponeurosis. So from the external oblique aponeurosis, it derives the external spermatic fascia, right? So these are the three coverings of the spermatic cord, right? So from internally to externally, the internal spermatic fascia, the cremasteric fascia, external spermatic fascia. I, C, E, that is ICE. So this is an abbreviated, you can use this as a mnemonic. I stands for internal spermatic fascia, C stands for cremasteric fascia, and E stands for external spermatic fascia. Now, I had mentioned that the inguinal canal, these are the normal constituents, but then again, there can be some abnormal constituents as well. The most common abnormal constituent of the inguinal canal can be, if you remember what I had said, why is the inguinal canal formed in the first place? Due to the descent of the gubernaculum, right? For the descent of testis is a very important topic, which again later discussion. So suppose that testis is not descent, so it can be a constituent abnormally. It can be a constituent of the inguinal canal. Then again, the ovaries, they should not descend to as far as the inguinal canal, but if they do descend, then they will be an abnormal constituent of this as well. So, undescended testis is an abnormal constituent, but hyper-descended or more descended ovary is also an abnormal constituent, or rather can be, right? And then, as I had mentioned, in the spermatic cord, that the accessory spleen can be an abnormal constituent. The accessory suprarenal cortical tissue can also be an abnormal constituent, right? So this is more or less about the inguinal canal, right? We'll talk about the inguinal hernia in the next discussion. So this discussion was much more concentrated on the, you might say, the aspect of understanding how the inguinal canal is oriented. Because what happens is that most of the times, this also used to happen with me, uh, since inguinal canal is a short topic, either people overlook it, or even if they do study it, they kind of memorize it up. This is a, I would say this is a pretty difficult topic to visualize, since there are so many minute things to remember, or not to remember, actually to understand. So for that reason, I kind of concentrated on the more logical or more anatomical aspects of it. The more theoretical aspects, although if they are there, I think you're very well equipped to handle them, right? So with that being said, I hope if you did stick around for this long, thank you very much. I do appreciate it. And thank you if you did find this useful. And yeah, okay, goodbye.